This hearing will come to order. This hearing is fully virtual, and we must address a few housekeeping matters. For today's meeting, the chair or the staff designated by the chair may mute participants' microphones when they are not under recognition for the purposes of eliminating background noise. Members, you are responsible for muting and unmuting yourself. If I notice you have not unmuted yourself, I will ask you if you would like the staff to unmute you. If you indicate approval by nodding, staff will unmute your microphone. I remind all members and witnesses that they have a 5-minute clock that should be on display, and that's going to apply. If there is a technology issue, however, and we do have 2 of them going on right now, we will move to the next member until your issue is resolved, and you will retain the balance of your time. You will notice a clock on your screen, and if you're in the grid layout, the clock should pop up, and it will show how much time that you have remaining. A 1 minute will turn yellow. At 30 seconds remaining, I will gently tap the gavel to remind members that their time is almost expired. When your time has expired, the clock will turn red, and I will begin to recognize the other member. In terms of speaking order, we will follow the order set forth in the rules of the House, beginning with the chair and the ranking member. When members are present at the time the hearing is called to order, they will be recognized in order of seniority. And Mr. Womack and Mr. Diaz-Balart have been trying to check in, and so their seniority, if we can get things working, will remain. I see Mr. Womack here as you know, having been present when the gavel went down. Final members not present at the time the hearing is called to order will be recognized. Finally, House rules require me to remind you that we have set up an email address to which members can send anything that they wish to submit in writing at any of our hearings or markups, and that email address has been provided to your staff. So let's get going. The defense on the Subcommittee on Defense is in order. This morning, the committee will receive testimony on defense health programs and medical readiness, and we welcome 5 witnesses. Dr. Terry Abraham, Assistant Secretary of Defense for Health Affairs, Lieutenant General Ronald Place, Director of Defense Health Agency, Lieutenant General R. Scott Ringgold, Surgeon General of the U.S. Army, and Rear Admiral Bruce L. Gilliam, Surgeon General of the U.S. Navy, and last but not least, Lieutenant General Dorothy A. Hogg, Surgeon General of the U.S. Air Force. Our witnesses have extensive experience in military medicine and distinguished careers in serving our country. On March 5th, 2020, the subcommittee held its last in-person hearing just prior to the shutdown due to the pandemic, and many of our witnesses were present for that hearing on health defense. Dr. Abraham, this is your first time before the subcommittee, and we welcome you. Much has changed since March 2020 due to COVID-19, and there are still many pressing issues impacting the military health system as it undergoes its most significant changes in decades. Reforms that began prior to the pandemic, which we now hope to review in light of the pandemic. We are holding this hearing days before the anticipated release of the President's budget request for fiscal year 2022. And it should be noted that we have serious questions and we have concerns on how medical reforms have been accounted for in the previous budget submissions. We hope to see adequate justifications and details across the spectrum of the military healthcare service system's request for medical readiness to benefit care. By understanding that we do not have yet the 2022 budget request before us, we hope our witnesses will address our questions and concerns to the extent possible on the many topics that will be covered today and get back to members and staff promptly as soon as the budget request is before us. Given in the tight time frame that we have to write the bill, I ask that you really be prepared to respond to members, as I said earlier, on any specific budget questions that are asked today immediately after the full request is submitted. It would be helpful to hear an update on the execution of the Defense Health Program during the fiscal year, given the projected shortfall you are facing. We also look forward to hearing about the many reforms taking place across the military healthcare system. We will want to hear how the experience of COVID-19 has been taken into consideration as the department moves towards the implementation of those reforms. We also look through a broader lens of lessons learned from COVID-19. We want to hear your thoughts on what the department's role is and should be in assisting other federal agencies in dealing with future pandemic and epidemic outbreaks. We have the services surgeon generals before us to discuss medical readiness and activities and priorities within each of the military branches. Part of the medical readiness requires that we all have a fit and able-bodied force to serve and deploy as necessary. Reports have indicated, and it's been recently in the media again, 26% of 17 to 24-year-olds are qualified to serve in the military, and that 1/4 of all youth would be disqualified from serving based on being overweight or obese. As the service continues to see recruiting and retention challenges based on weight standards, it would be good to hear whether our panelists see this as a national security concern, and if so, what can be done about it. As we all know, any future conflict, the military must consider survivability during the war fight against peer or near peer competitors, and is called the golden hour, and this cannot be an option. It is especially the case if air and ground assets are unavailable to evacuate the wounded. We would like to hear about how the right composition of medical research, medical education and training, and recruiting and retraining critical casualty care is being addressed. New questions have also arisen from the hearings over the past few weeks. For example, we've heard approximately 600,000 guardsmen lack health insurance. We also heard about the possible decrease of medical billets as the service plan to shed those positions in favor of operational billets in support of more lethal force. If this is the case, where medical positions are being left deliberately unfilled, that would be quite concerning to me and to the members of this subcommittee. We do understand that the past year has presented a number of complicated challenges across the military healthcare system, and I want to thank each of you for working in support of our service members and their families to ensure that they're protected and provided with the best care available. With that, I thank you again for appearing before the committee today to discuss these issues. But first, I will ask you, as you present, to summarize your statements in a moment. But first, I'd like to recognize our distinguished ranking member, Mr. Calvert, for his opening comments. Mr. Calvert.
Thank you, Madam Chair. Acting Secretary Durham, General Place, Surgeon Generals Dingell, Gillingham, and Hogg, welcome, and thank you so much for taking the time to meet with us today. First, on behalf of a grateful nation, I want to commend you and all the men and women serving under you for the unprecedented efforts you undertook during the pandemic, from the deployment of hospital ships to the rollout of vaccines. The military has been crucial in healing our nation. Yet those efforts require resources. And while Congress can appropriate dollars after the fact, adequately funding base budgets is the only way to properly resource the Department of Defense for such future contingencies, which is why it's so disheartening that the president is proposing a woefully inadequate budget for defense, one that does not even keep up with inflation. Unfortunately, we still do not have the president's full budget request, and hopefully we'll have it at the end of this week. So we're unable to discuss your resourcing needs for fiscal year 2022. Instead of specific resourcing requirements, then I'll be interested in hearing from you on some subjects of concern. Specifically, lessons learned from the pandemic response, the ways you have utilized new technology in your services and overall military health system. Even before the onset of the pandemic, the military was struggling with transitioning certain service responsibilities to Defense Health Agency. I'll be interested in an update on those efforts. I'd also like to hear more about the impact of the pandemic on the provision of healthcare going forward. For example, whether the return to normalcy will create a spike in funding needed for private sector care, as well as any tactics, techniques, procedures developed during the pandemic that may be retained, such as telehealth appointments and the health protection condition scale for our deployed and afloat forces. Finally, I'd be interested in hearing from you on the overall health and readiness of the force and whether we're ready to resume normal operation once again. Again, thank you for joining us today, and thank you for your service. I look forward to your testimony, and with that, Madam Chair, I yield back.
Thank you so much, and I couldn't agree with you more on your statement. To the witnesses, your full written statements will be placed in the record, and members have had copies mailed available to them. So I'd like to have as much time as possible for members to ask questions. This is an important hearing. So I would encourage all of you to summarize your statement and to be complete but succinct in responding to members' questions. So first, we will hear from Dr. Adiram. Thank you for being with us.
Yes, and thank you. Good morning, everybody. Chair McCollum, Ranking Member Calvert, distinguished members of the subcommittee, I am honored to represent the military and civilian medical professionals in the military health system who are serving around the world and here at home, delivering healthcare and support of our 9.6 million beneficiaries, as well as continuing to provide COVID-19 support to millions of Americans throughout the United States. My written testimony provided the subcommittee with information on major activities that will inform our budget proposal for the coming fiscal year. The most significant issue looming over all of our projections is the COVID-19 pandemic. Secretary Austin has made clear that the greatest proximate challenge to our nation's security is the threat of COVID-19. The department has and will continue to act boldly and quickly to support federal government efforts to defeat this disease. We remain deeply appreciative of the fiscal 20 supplemental appropriation of $2.2 billion as part of the CARES Act that covered the significant costs incurred during our initial response. In fiscal year 21, however, costs attributable to the pandemic response continue to accumulate. As of March 31st, 2021, our mid-year review of the Defense Health Program identified likely shortfalls as part of the ongoing pandemic response, which we are working within the department to resolve. In addition, the financial impacts of our military support to the Federal Emergency Management Agency missions, which remain ongoing, are still being assessed. The department continues to pursue efforts focused on internal business process improvements and structural changes to find greater efficiencies, such as further integrating and standardizing the operation of hospitals and clinics, continuing the deployment of MHS Genesis, modernizing clinical and business processes, and streamlining internal operations. Furthermore, the department is not requesting any changes to beneficiary cost sharing in the fiscal year 22 budget. Finally, the department is grateful for this committee's long-term advocacy and support for our military medical research program. Military medical research advances the state of medical science in those areas of most pressing need and relevance to today's emerging threats, which includes the COVID-19 pandemic. When released, our fiscal year 22 budget will present a balanced, comprehensive strategy that aligns with the Secretary's priorities to include the ongoing response to the COVID-19 pandemic. We look forward to working with you over the coming months to further refine and articulate our objectives in a manner that improves value to everyone, our warfighters, our combatant commanders, our patients, the medical force, and the American taxpayer. Thank you again for this opportunity to testify today, and I look forward to your questions and the discussion.
Thank you so much. Lieutenant General Place, your testimony, please.
Committee, thanks for the opportunity to appear with the Acting Assistant Secretary of Defense for Health Affairs, Dr. Durham, and the Service Surgeons General to discuss our budget for the coming year. It's a privilege to serve with the men and women of the Defense Health Agency, provide integrated health services worldwide on behalf of our armed forces. The Defense Health Agency is actively engaged in the global COVID-19 pandemic response in preventing, diagnosing, and treating COVID-19. On the prevention front, as of this morning, more than 60% of our active duty have received at least one dose, and 46% of the force are fully vaccinated, with this number climbing daily. We've directly administered almost 3.5 million doses to our eligible beneficiaries and coordinated at least another 800,000 doses of vaccine to our TRICARE providers and retail pharmacy networks. To meet urgent healthcare needs throughout the pandemic, the department significantly expanded the use of virtual health to meet beneficiary demand while minimizing unnecessary risks for patient and staff. With our vaccination rollout now reaching our entire population of eligible beneficiaries and the risk of COVID infection falling rapidly, we're communicating with our beneficiaries who may have delayed or deferred needed preventive and routine medical care due to the pandemic to ensure they get timely, high-quality care. As Dr. Durham noted, following a brief pause to the pandemic response, the military health system has resumed executing the transition of military medical treatment facility administration and management from the services to the DHA in accordance with the law. Similarly, the department submitted its required report to the Congress in February 2020 on our plan to restructure MTFs. The report articulated the DoD's decisions to achieve a proper balance between meeting readiness requirements and managing the total cost of healthcare in the direct and purchase care systems. The department is revalidating the assumptions made regarding its readiness requirements prior to the pandemic, as well as the assessment of network capacity to absorb additional patients where we intend to proceed with right-sizing plans. Local transitions will only occur when we are certain that the TRICARE network can provide timely and high-quality access to healthcare for our beneficiaries. If they cannot, we will revise our plans. Again, thanks for inviting me to speak with you about military medicine, our response to the global pandemic, and our plans to further improve our military health system on behalf of the uniformed service members and the families we serve.
Thank you so much. Lieutenant General Dingell, please.
Chair McCollum, Ranking Member Calvert, and distinguished members of the subcommittee, thank you for your support and for the honor to speak to you on behalf of over 83,000 active duty Guard and Reserve Army soldier medics. COVID-19 and unexpected challenges attempted to attack the foundation of our nation, but it did not disrupt the fabric of our Constitution and its Army's response to its call. I honor the soldiers that I am privileged to lead. As our 40th Chief of Staff of the Army states, people first, winning matters. I am proud to say that our Army is ready to win. Within days of our nation's COVID call, we collaborated with Health and Human Services, the Department of Homeland Security, the Defense Health Agency, and our state governments as we expanded critical testing capacity, inculcated 200 retiree recalls, deployed vaccine and medical teams in support of civilian entities, and partnered with medical research and development in support of the whole of government approach. Soldiers deployed to 3 countries, 19 states, and 3 territories to include Arizona, California, Florida, Illinois, Ohio, Texas, and Washington State to support and to save American lives. You called, we were ready, we responded. As 30th of September approaches and authority, direction, and control of our MTFs transitions to the Defense Health Agency mandated by law, my vision for the Army medicine is clear as ever. We will be ready, reformed in accordance with the law, reorganized, responsive, and relevant in this era of unprecedented global complexity, whether in support of our national defense strategy and whenever our government calls. So when the Army deploys today and fights tonight, Army medicine will be right there to return them to duty tomorrow. From the foxhole to the fixed facility, we will conserve the health and fitness of the fighting force and reinforce our readiness requirements through health care for our beneficiaries. I will ensure that integrated medical efforts occur with strong fiscal stewardship and partnership between Army medicine, the Joint Force, and the Defense Health Agency, ensuring the readiness of our soldiers. The vision and operational focus for Army medicine remains at building readiness in properly manned and proficiently trained units and modernizing to remain ready and relevant for future conflicts and challenges. Medical reform directives will be implemented to maximize readiness in support of the Army mission. Finally, we are committed to sustaining and improving our partnerships, foreign and domestic, to elevate battlefield interoperability and to support our national defense strategy. In closing, I thank the committee for your long-standing support to the Army and military medicine. I look forward to answering your questions.
Thank you. And when I was reading your testimony, I did underline from the foxhole to the facility. I thought that's true in all the branches of service, taking care of folks. Rear Admiral Gillum, your statement, please.
Yes, thank you. Chairwoman McCollum, Ranking Member Calvert, distinguished members of the subcommittee. It is my privilege to update you on Navy medicine. I'm grateful for your continued support as we execute our medical readiness mission in support of the United States Navy, United States Marine Corps, the world's premier naval force. The last year has been like no other in our lifetimes as we confronted the SARS-CoV-2 virus and the disease it causes, COVID-19. Throughout the pandemic, Navy medicine's operational tempo has remained high, protecting the readiness and health of our sailors, Marines, and their families, along with making direct contributions to the whole of nation response. I want to assure you that despite these unprecedented challenges, the One Navy Medicine team remains relevant, ready, and responsive. We are guided by our strategic priorities: people, platforms, performance, and power. Well-trained people working as cohesive teams on optimized platforms, demonstrating high reliability performance that will project medical power in support of naval superiority. With the earliest identification of the virus, it was evident that we were battling an adversary whose behavior was highly unpredictable, particularly with respect to its asymptomatic transmission. Actions and interventions by experts across Navy medicine during early stages directly impacted our ability to better understand the virus, mitigate and contain its spread, effectively supporting ongoing fleet operations, and preserve fleet and Marine Corps readiness. We rapidly applied lessons learned from the early outbreaks on board USS Theodore Roosevelt and USS Kidd, and continually incorporated the latest critical information from the CDC, as well as our Navy medicine, public health, and R&D experts. I want you to know that our sailors and Marines demonstrated tremendous personal responsibility, resilience, and adaptability in responding to the pandemic. Their work, in concert with a strong commitment from our naval operational leaders, has been instrumental in allowing our ships and personnel to stay mission capable despite the pandemic. Our highest priority remains ensuring that all Department of Navy personnel have access to the vaccine in order to protect themselves, their shipmates, their families, and their community. As the Navy Surgeon General, I've been very clear in my guidance that these vaccines offer the most effective protection against this deadly virus. The bottom line is that we are getting shots in arms and providing our personnel with what I refer to as biological body armor. To date, Navy sites have administered nearly 1 million vaccines, and over 50% of sailors and Marines are now fully vaccinated. Navy medicine continues to answer the call to help our nation. Navy and Marine Corps personnel are now currently deployed around the country to assist with vaccination administration in community vaccination centers. I recently had the opportunity to see firsthand the significant impact they are making in the lives of our fellow citizens affected by the virus. In summary, the nation depends upon our unique expeditionary medical expertise to support our naval forces. The Navy medicine team, some 63,000 strong, is privileged to be entrusted with these responsibilities. Again, thank you, and I look forward to your questions.
Lieutenant General Hawk, please give us the statement, and then we'll continue to questions.
Thank you, ma'am. Chairwoman McCollum, Ranking Member Calvert, and distinguished members of the subcommittee, thank you for the opportunity to testify on behalf of the more than 55,900 active duty, Guard, Reserve, and civilian airmen who comprise the Air Force Medical Service. Your sustained confidence and support enables us to remain mission-focused, excellence-driven, and ready to fight tonight. Over the past year, our airmen have been involved in every aspect of the COVID-19 response, from the early days of initial public health emergency response to supporting the whole of government vaccination efforts. Air Force medics showed their ability to innovate. When COVID-19 epicenters in New York, California, Texas, and North Dakota were facing critical staffing shortages, we acted quickly, enabled critical care strike teams directly into civilian facilities. Today, we have deployed over 1,000 Air Force medics to FEMA vaccination sites in 13 states to administer COVID-19 vaccinations. And as of yesterday, we have given over 1.3 million vaccines. A year before the first COVID-19 case hit the U.S., we established our newest critical sustainment CSTARS training program at the University of Nebraska, Omaha. This Center for the Sustainment of Trauma and Readiness Skills focused on disease containment. Our infectious disease specialists worked alongside civilian counterparts to treat some of the very first COVID-19 patients using the university's biocontainment unit. We took our air medical evacuation capabilities into new territory when we were tasked to transport COVID-19 patients. Early in the pandemic, the rapid rise of cases drove the need to move more patients at once while mitigating the spread of COVID-19 to aircrew members. We partnered with teams across the Department of Defense and the civilian industry to develop a new infectious disease transport system called the Negatively Pressurized Connex. This Connex can safely transport up to 3 times as many patients as the previous isolation system. And as of the 24th of May, we have completed 101 missions and moved 372 COVID-positive patients. While battling the pandemic, we also remain dedicated to the military health system transformation efforts. We have worked side by side with the Defense Health Agency to identify all necessary processes needed to mature the Defense Health Agency's functional capabilities. We also implemented a new reform model to improve our airmen's and guardians' readiness and deployability. We reorganized our military treatment facilities into 2 squadrons. The first squadron focuses on the health of airmen and guardians, and the second squadron focuses on the care of all our other beneficiaries. This new model has been implemented at 66 bases, and early analysis has already shown the model enhances force readiness and lethality. This pandemic brought unprecedented challenges, but it also provided opportunities to accelerate change or lose, to become more agile, resilient, and capable to face the unknown. This is what we train for. We remain ready for the fight as we evolve to face the next major threat. It has been an honor to serve as the Air and Space Force Surgeon General alongside extraordinary medical professionals on the joint team. This is my final time to appear before this subcommittee as I will be retiring next week. Thank you for your continued support and for the opportunity to address you today. I look forward to answering your questions.
Well, thank you. I thank you all for your testimony, and we wish you the best in your retirement, but we're gonna take advantage of your expertise for as long as we have you, especially today. I'm going to recognize myself for a few minutes here, but I'm going to try to set an example of directing questions to specific witnesses and maybe not hear from every witness on everything. Sometimes we'll need to. And on the WebEx chat, you're going to find members so you know your place in line. So let's start with the first question that I have here. And I want to go to COVID-19 because in all your testimony, there was discussion about lesson learned. So I'm going to set the scene here for a few minutes. As of May 19th, there have been 193,736 cumulative across the military cases of COVID, 28 deaths. And right now we have active cases, 5,271. So more than a million military members have either been fully or partially vaccinated. Congratulations on that. And forces deployed in support of community vaccination centers was 4,749. And then we all know that Congress has provided, a lot of dollars to the Defense Health Program. So I'm going to ask a question for each one of you, and I want you to be very brief in it. And I'm going to use the example of measures being taken to reduce the risk of COVID. Admiral Gillum, you talked about how you worked on confined spaces, ships, and submarines, and worked to reduce the spread of COVID. Could each of you briefly tell me your one big takeaway lesson learned on COVID? And if you could just do that in 30 seconds, your big takeaway. I know you have a lot, but just your big takeaway. And we'll start with the Admiral, and each of you, please then just follow in order.
Thank you, Chairwoman McCollum. I think the biggest takeaway for me is the value of our public health, infectious disease, and preventive medicine experts. They labor often in the shadows while we think about and focus on trauma and casualty care, but they have been the heroes. And so they, along with our researchers and our public health experts, maintaining a strong research program, I think is going to be critical going forward, as well as maintaining our network of overseas laboratories and environmental preventive medicine units that are out there on the forefront, on the vanguard of detecting emerging disease. Thank you.
Somebody else, if you share the same thing, give us your next lesson learned. Maybe we'll start with Mr. Place. Excuse me.
Yes, ma'am. For me, it's leveraging telehealth. We've used it some before the pandemic, but at peak spring, summer, almost 50% of our primary care appointments were utilizing telehealth. So enabling to continue the conversations with our patients to maintain or even new challenges or new disease processes, but be able to work with them using technology. Over.
Dr. Durham.
Thanks. I wasn't here during most of the pandemic. So looking back historically, I think one of the things that impressed me was how quickly the department pivoted to a forced health protection posture. There were evidence-based policies and procedures that were implemented that I think really reduced the number of cases, deaths, and hospitalizations. The numbers that you cited are for all of DoD, so it's not just for the uniformed force.
Right.
If you look at just the uniformed force, I think we're well below the civilian sector, and I give credit to the force health protection procedures and the execution by the services, as well as, I just have to add in a second one, the pivot to prioritizing testing and really using it in a strategic manner to augment our force health protections.
Thank you. Thank you. Lieutenant General Dingle.
Ma'am, I would say mission, command, flexibility. And what I mean by that is it was a tremendous lesson and honor to watch the services respond to the nation. The ability to cross-level the uniformed forces when soldiers, sailors, and airmen deployed out of the MTFs and then they had to be backfilled. The ability to organize forces as an urban augmentation medical task force, whether in New York, Seattle, or across the country, vaccination task force teams deploying in support of the states. And then finally, it would also be the integration of that mission command flexibility by the senior commanders in the field, where now the medical personnel were at the table, commanders were listening, and then they were executing to protect the forces at their post camps and stations.
Thank you. Lieutenant General Hogg, quickly, please.
Yes, ma'am. Public health one, and second, innovation to deliver care and to get the mission done. Our medics took it upon themselves to figure out how to deliver care either face-to-face or virtually that protected not only the patient but themselves, and also to give guidance to mission commanders in order to keep the mission going.
Okay, thank you. Then I have two follow-up questions, and I'm going to direct them to first to Mr. Place and then Ms. Adiram. So first, Mr. Place, what have you learned about staffing in military facilities in instances that military healthcare personnel have been called upon by civilian agencies for assistance? In other words, when we drew out to help with testing, when we draw out to help with vaccines and other things like that, or to move forward or move you around, that creates a wholesome other place. So lessons learned from that. And if there's more than you can say in 60 seconds, we look forward to a fuller explanation provided to the staff, and I'll share it with the members.
Yes, ma'am. I think it's what General Dingle said, and that's mission command. Prioritizing the work that must be done today with the most urgent requirements for healthcare delivery. So it's the leadership locally reorganizing the staff they have. Sometimes that means taking inpatient or outpatient staff to the inpatient mission. Sometimes it means taking administrative staff and putting them at vaccination sites. But it's all about knowing who you have, what their capabilities are, and utilizing your talent in the most or the highest priority areas on the day that you need them. Mission command, ma'am. That's the way I see it.
So you, did you feel you had limited risk at the MTFs for the service members and their beneficiaries as you were doing that?
So with the ability to partner with the network, so with the private sector care, I don't recall a single area where we had significant long-term concerns about the ability to provide healthcare based on mission command on the installation and integration with the downtown medical care. Over.
Okay, thank you. Dr. Jerem, one thing that I know we continue as members to be concerned about is addressing industrial base issues, especially PPE items that were in short supply because they're manufactured elsewhere. What is the department proposing to happen for that?
Well, I think we were in a very good position. We had a fairly large stockpile, which in fact we shared with the rest of the nation. I believe it was 20 million N95 masks that we shared with the United States. I think it's a matter of strengthening our supply chains. And I know that that's something that our USD for Acquisition and Sustainment is working with across the federal interagency to do that.
Thank you. And I think the members, I went over 5 minutes doing that, but I wanted to make sure we got everything in on COVID and we all had an opportunity to hear that. With that, I turn it over to the gentleman from California, Mr. Calvert.
Thank you, Madam Chair. I have a question for all the Surgeon Generals, and that's related to medical readiness. Obviously, we got significantly diverted because of this pandemic, and rightfully so. We had a logistical issue, we had research issues, but let's go back to our primary focus, and that's our medical readiness if unfortunate war happens. I think that the military does a good job of basic health care, obviously research. We've talked about your interaction with the private sector. But what I worry about is if we have a significant interaction with a near-peer adversary, how prepared are we to provide immediate medical care for the men and women who may be caught up in that conflict? And that's for all the Surgeon Generals.
Yes, sir. I'll go ahead and start. We are prepared to provide the care anytime, anywhere. We have not skimped on maintaining the readiness of our airmen and medics. We are looking at what the near peer fight will look like and tailoring our services to that. So as a matter of fact, doing mobile ground surgical teams and increasing my critical care air transport teams and the capabilities like that. So we definitely are ready for the next fight. Over.
Sir, I would say for the Navy, we recognize and have been doing a tremendous amount of work on being able to operate in a distributed maritime environment, as well as and to provide medical care and in expeditionary advanced basing operations to support the Marine Corps. We've done several exercises, tabletop exercises, and work to identify the capabilities required to do that. And I'm excited to say that we're looking forward to the delivery of EPF Flight 2, hull number 14, which will allow us to provide ambulance ship-like connectivity close to the weapons engagement zone. So we are definitely moving out in those concepts.
Admiral, you especially, what kind of equipment do you have? Obviously, the Pacific is a big area to move healthcare rapidly to an area you may not know where you're going to be sending in the next, say, week if something happens.
Yes, sir, and that's the fundamental concept behind distributed maritime operations. Instead of large strike groups, for example, having more surface action groups distributed across that environment that have small surgical teams that are capable of doing initial damage control surgery, And as well, that Role 2 capability I just described aboard the EPF Flight 2, which will allow us to respond to a ship in distress, for example, be able to do initial damage control surgery aboard, and be able to evacuate those casualties using Osprey aircraft.
Okay.
And then, sir, I'll close with a comment. General McConville tells us that we cannot telework to combat. And so we turned on the training machine last summer in the Army in the new COVID environment. So we're executing the emergency deployment readiness exercises. We have large exercises like Golden Medic, Defender 21, in which medical forces are fully inculcated in there. And then also we have the individual exercises that we're leveraging, things like the Expert Field Medical Badge, individual critical task list of ensuring the readiness of the individual soldier. So when they're called upon to deploy, fight, and win, they have the acuity and able to do that. And then finally, the partnership with the DHA, leveraging the health readiness platforms, our medical treatment facilities, to get after the acuity that they need to deploy. So when we do deploy them in support of vaccine teams or urban augmentation teams, that we're also capitalizing those individual skills that reinforce those that are required when they deploy to fight and win.
Okay. Thank you. Obviously, it's something we none of us want to see happen, but we have to be prepared if something does happen. And I'd like to get into that more depth to make sure sometime, Chair, that maybe we can get into that to make sure that we are prepared if in fact the conflict does occur. I yield back.
Thank you. I agree, Mr. Calvert, and you and I asked some really broad questions. So members, what's in the chat room is the same order I have on the paper in front of me. So we're in a good spot. Thank you so much for the team for getting that in there. So we'll have Mr. Ryan followed by Mr. Rogers. Mr. Ryan.
Thank you, Madam Chair. This question I have is for General Dingle and General Hogg. I'm sure you will agree that the health and medical readiness of our service members and their families is critical to the optimal performance on the battlefield. And here in Congress, we hear a lot from the services about the human performance optimization, and the services are doing some pretty amazing things when it comes to maximizing our human capability. And I think the medical and the health community is doing a good job in advising the services on the nutritious ingredients we should be using in food that is prepared and served or sold on our bases. And where the services are falling woefully short is in the area using these standards to make high quality nutritious food available to our service members and their families, and incentivizing them to actually eat the food that is made available. And the high cost of tolerating obesity in our service members, their families, and veterans falls squarely on the backs of the taxpayer. So let me be clear, I don't believe the problem is a lack of understanding of good nutrition. The problem is an antiquated food delivery system that fails to make nutritious food available in adequate quantities and fails to make the right choice, the easy choice for the customer. And if you look at a graph of the the supply chain of how to get food ordered, it's an incredibly cumbersome, complex series of bureaucracies that you need to learn how to navigate. And so this committee and the American taxpayer need your help and support in the transformation of the entire installation food delivery system. While dining facilities generally provide nutritious offerings, many more meals are eaten each day at the myriad of on-base fast food joints, snack bars, and base restaurants. I know that you do not control the system, but you do have influence. And I just would like to know if you will support this initiative. And if so, I'd very much like to hear your ideas on how you can help.
Yes, thank you for the question. So I definitely do support the initiative. And in the Air Force, we use the DoD tool called MNEAT. It's the Military Nutrition Environmental Assessment Tool. So at each one of our installations, we have either public health or a dietitian who goes around the installation and does an evaluation of the nutritional offerings on base, and then gives that report to the installation commander And then they are part of a committee who then looks to see how they can improve it. So they identify good food opportunities. We identify where we can do better as far as vending machines and putting healthier options in vending machines. And we talk to all the other installations on base. So I definitely support any initiative that we could do to make that better.
And sir, I would add, I absolutely also support 100, and 90%. We are nested tightly with our Army Materiel Command and Installation Management Command, and getting after programs like the Holistic Health and Fitness, the Performance Triad, our Army Wellness Centers, Go Green initiatives that are in our dining facilities, our Warrior restaurants, our individual initial entry training, soldier fueling programs, all which get after what you talk about. In addition to that, myself and my Command Sergeant Major, we engage every commander on a monthly basis at our pre-commanders course to get it to start at the top, to educate them in conjunction with those things that are going to produce a healthy warrior.
Well, I would really appreciate your help. We've I know you're retiring, but I would love to get your help on this. This has been something we've been working on, and we look at the amount of money we're spending on healthcare, the number of our troops that have diabetes, and it doesn't just affect the Department of Defense. Last Congress I sat on the Veterans the subcommittee, and when we look at veterans healthcare, a lot of these habits and problems started when they were active duty, but it's still costing the taxpayer money. I mean, we just got to be smart here in how we're running our operation, because I think we can, obviously we're having very difficult decisions that we have to make across the budget with multiple threats around the country. We shouldn't be blowing money on, because we can't get diabetes under control within our rank and file. So anyway, I appreciate your service. Thank you so much. Yield back.
Thank you.
I yield back nothing, Chairwoman. I have nothing to yield back. Thank you.
Well, I know if you would have had an extra second, you would have talked about the statistic that I gave with 26% of the population of 17 to 24-year-olds not being in good health to serve in the military due to weight and obesity. So we need to work on it in the school level as well. Mr. Rogers, I understand you got a little bit of an extra briefing on medical records. You've been the leader on that. Without Ms. Lowy here, I wanted to make sure you got as much information ahead of time on it. So we look forward to your questions now, sir.
Well, I thank you, Madam Chair. I will defer the electronic records discussion to another time when we can focus on it in its entirety and solely. Today, I'd like to ask briefly about mental health care in the services. Dr. Adram, or any of you, go into detail in how you've seen the COVID-19 pandemic affect our service members' mental health.
Sure, and we really appreciate the question, because this is something that is very important to us and is critical that we provide as good access to mental health services as we can, not only for our uniform service members, but also for their families. And the pandemic, as you're aware, has had an impact on many of us just in general. And so likely it has had an impact on our beneficiaries. There's been a number of things that we have done in order to ensure access. As General Place mentioned in his opening remarks, we, along with the rest of the country, really opened up virtual health to not only protect people during the pandemic, but also to ensure that they had the services that they need. And the one area that has been a success and that we're continuing to study and plan to keep is virtual behavioral health. So what we have found is that there is an increasing need, and we are committed to meeting that need, whether it's direct care, purchase care, virtual health, any way that we can.
we've got an epidemic going on inside the pandemic. The COVID-19 pandemic, of course, has changed a lot of everything. But the epidemic that's going on all the while and really little noticed is the overdose deaths from opioid abuse. At least there was a 27% jump in opioid overdoses nationwide in 2019. And so, what do you think?
Mr. Rogers is resetting. We'll give him an extra. Okay, so he still has time remaining. If he doesn't come on in the next 10 seconds, we will move to Mr. Cuellar. So Mr. Rogers, staff is on. Please let him know that we have reserved 2 minutes and 17 seconds for him. Mr. Cuellar.
Thank you, Madam Chair and Ranking Member, and to all the witnesses. Thank you so much. I want to follow up on where Mr. Ryan was working on, except I want to cover more than just nutrition. One of the things that I think we need to look at, and I'm proposing and waiting for the committee to decide on this, but I also want to focus on developing the utilization of human performance optimization across and throughout the military services. But it's not only the nutrition. I think we need to optimize physical fitness, especially if you look at a recent 2020 study across the military that lower extremity overuse injuries and musculoskeletal injuries are the leading cause of being medically not ready for duty. So it's physical fitness, nutrition, sleep, and psychological wellness, which are those are the elements of the human performance optimization. One of the things I will be asking if the committee goes along with my request is for the department to employ a comprehensive evidence-based program to educate service members on all avenues to optimize human performance and look at specific measures to sustain the mission success. And also ask you all to enhance any partnerships with civilian institutes and work with them to enhance this program. I know, for example, when some of us were at the West Point Academy, they're doing some work there also. And I know I did some research on my own, and there's really so much literature out there that the military is doing. So one of the things we will ask is that you all do a consolidated inventory of all HPO research efforts within the Department of Defense and any other agency, so we can put it together in a one-stop center. So I would like to just get your thoughts on what you're all doing, because the research I've done is there are so many efforts out there, but I don't know if it's consolidated on the areas nutrition, physical fitness, sleep, and psychological wellness within the HPO. So I'd like to get your thoughts on that.
Yes, sir. General Hogg, I'll go first. So in the Air Force, we see ourselves as the maintainers of the human weapon system. And so human performance is incredibly important. And we need to go where the airmen are at, first and foremost, and that is to their work sites. So we have instituted integrating operational support teams that go out into the units to evaluate what they're doing, how they're executing their mission, and what we can do to prevent injury. We all know that musculoskeletal injury is the #1 cause for service members to not be ready to do the mission. So what can we do ahead of time to help them prevent those musculoskeletal injuries? I also embed medics into units. There are some units that should have embedded medics all the time. Our special forces are very specialized units. They are physically challenged all the time in doing their mission. So how do I make sure that if they get injured, that they have the care immediately on site to prevent any long-term outcomes? So embedding physical therapists, athletic trainers, mental health folks right into the units so members become comfortable seeing, talking to, and addressing their issues. So that's one thing that we're doing in the Air Force to help that.
Can I ask you this question? Sorry to interrupt. Is there a comprehensive consolidated inventory for what the Air Force and the other armed services are doing, number one? And do you all work with civilian? For example, you got some of the elite athletes out there, for example, well, without going any, particular one, but there are elite athletes, where those organizations do a lot of work. Is there a consolidated inventory of what work you all do together, or does every branch do it separately? And I'm sorry, I got 20 seconds and my time is up. I apologize for that. Love to follow up with you all on that. If you don't mind, to all three witnesses, if you can follow up with the committee on what each of y'all are doing and if there's any consolidated work on this. Thank you so much, Madam Chair. My time's up.
Thank you. Thank you. We've got a lot of universities working on that. So Mr. Womack and then Mr. Kilmer. Mr. Womack, please.
Thank you, Madam Chair. Hey, by the way, any savings we get out of any cuts that happen, I recommend some of it go to Pulaski County, Kentucky for some rural broadband so we can get Hal Rogers back on here. Just a thought.
Is it the President's infrastructure plan?
There you go. Hey, thanks to the panel today. A couple of real quick questions, and I got another more formal question. I know we've talked a lot about COVID, but and we've kind of danced around the subject. But one of my concerns about COVID, as it was in the civilian community, in the heat of the moment, we delayed a lot of elective surgery, a lot of non-urgent care type surgeries and this sort of thing. From the military perspective, where are we? And this is specifically more to the maybe to the Army. I don't know. All the services probably can respond to it. But where are we in relation to, from a readiness perspective, anything that happened or was delayed as a result of COVID, the non-urgent sort of things that do go to readiness and medical fitness in the event that we had to fight tonight. So real quickly, if you could cover that particular subject on COVID.
I'll open real quick briefly, and that's where the synergy of the services and Defense Health Agency, as we've turned the surgeries and all the readiness requirements back on, we're prioritizing getting our soldiers, in my case, the things that they need to be medically ready. And so it's been a tremendous, again, partnership in getting after our pivot to readiness.
All right.
Same in the Air Force. We prioritized our military members' health care in the times that when it was limited, and we're now back full up round.
I understand you're prioritizing, but my question is, do we have a backlog? How does it affect readiness?
So I don't have a backlog because I took care of the care for our military members when needed.
Okay, what about Army?
No, absolutely same thing, sir. They were prioritized, and we were taking care of those issues.
Okay, so we don't have a backlog. What about the Navy? Are we good there?
Well, we're on track, sir. Yes.
Okay. Real quickly about the Guard and Reserve. They've been a very important partner of ours since 9/11. We've deployed them many, many times. I've always had concerns about their medical fitness and medical readiness. Under COVID, has it gotten worse? How do we assess? And this is primarily for the Army and perhaps the Air Force.
So from the Army perspective, it has not gotten worse. The standards of fitness we've maintained even in a COVID environment. We implemented force health protection measures for all of us to continue or maintain a level of medical readiness and fitness in itself.
Yeah,
Air Force?
Same for the Air Force, sir. It has not gotten worse. And when they are on orders and available to provide, to receive care, we provide it for them, whatever is needed.
Okay. Real quickly, University of Arkansas for Medical Sciences incredible research department has utilized DoD grants to study and advance things like bone regeneration in patients suffering catastrophic injuries. And this important DoD-funded research such as this takes place in universities and facilities all across our country. So the question for Dr. Adderam is, or Director Place is, given the potential shortfall of $1.8 billion, do you anticipate a reduction in the availability of this important medical research these grant programs?
I'll start and then I'll have General Place perhaps give a few more specifics. But we don't intend to reduce our research. It's so important to keeping us ready and keeping our forces ready across the spectrum, whether it's prevention, treatment, and rehabilitation, just like the type of research that you mentioned. So I'll turn it over to General Place.
Sir, quickly, those funds are fenced, and anytime that we would even consider moving those research and development dollars, we would come back to you first. No intention to move them over.
Good, very good. All right, I got about a half a minute left. I'm going to yield back my time, and maybe we'll have a round two. And if I'm still around, we'll come back and talk some more. Thank you so much for your testimony.
I just thought, Mr. Womack, you had a great question at the beginning. So the question, if you could get back to the committee on, did you keep doing surgeries? The hospitals in most of our states stopped doing elective surgeries. So is the reason why you don't have a backlog is that you were going ahead with, especially for readiness with service men and women, going ahead and doing anything that you needed to do. If you could get back, I thought Mr. Womack had a great question. I'd like to get that as some follow-up. Mr. Kilmer and then Mr. Diaz-Balart, who's joining us by phone, so he's incognito. So we'll start with Mr. Kilmer.
Thank you, Madam Chair. Lieutenant General Place, I'd like to ask you briefly about concerns I've been hearing from the folks I represent about the military health system reform. As you know, the DoD has been implementing this plan for restructuring and realigning the medical treatment facilities, but unfortunately, that realignment has already impacted access to care for our service members, including our retirees who've dedicated their lives to serving our country. My district's home to Naval Hospital Bremerton, and the realignment has really impacted the hospital, reducing about 100 billets from their manning document over the past year. So when hospital staff leave, either because they retire or move to another installation, their positions are no longer being filled. I know the realignment is not only affecting the military hospital in my region, but is impacting many other districts across the country as well. I've heard the DoD recommendation is to realign over 18,000 billets, reducing those billets from military treatment facilities and moving them to operational forces. Listen, I'm all for readiness, but we can't sacrifice the health of our service members and veterans. So unfortunately, we've seen some of these changes come at the expense of improving healthcare outcomes for the folks that I represent, including veterans and active duty military and their families, seeing them lose access to quality care. So I'm concerned about the ability of local civilian providers to adequately cover the gaps in care. For example, a veteran living in Kitsap County in my district could be forced at times to drive over 2 hours to receive treatment in Seattle. If you serve our country, the federal government should have your back, and these manning reductions mean we're failing to live up to that promise. So let me start with this question. What is the current status of the MHS reform, and what steps do you recommend are taken prior to the realignment's full implementation to ensure that service members and their families have uninterrupted access to quality providers?
Yes, sir. Thank you for the questions. So the way that you've asked the question is exactly consistent with the way that the Defense Health Agency is putting forward our plan. Our plan for that 703 reduction that you referenced, that Honorable McCaffrey submitted to the Congress last year, about February. Pandemic, of course, came in the meantime. We paused all transition plans and have been in the process of revalidating every single location. That revalidation has worked. It's now working its way through formal coordination within the department. My expectation is that report will come back to you sometime this summer. In the meantime, my responsibility, my requirement is to make sure that care can be delivered, whether that care is on site, on the installation, in our facilities, or in the network. And if we can't manage it in the network, then not reduce it within what's happening on the installation. Now, in order to accomplish that, as the services are moving their uniform personnel, that's where the dialogue happens between each of the 3 service surgeons general who are still in the Pentagon and me to make sure that we are synchronized, that we are inseparable on how we're managing the manning documents and our ability to provide care locally with either civilians hired in the installation or what we would send out to the network. So that's the very intricate dance that we do together. I hope that answered your question. Over.
It does somewhat, but maybe can you give us some insight into what level of analysis is done when we see the reduction of these billets and the cuts to these services? You know, what consideration is made to the availability of care and the proximity of care within the community, and what consideration is made to the impact that this will have on our service members? Because, you know, frankly, just in all candor, the sense from folks in our area is that there is not adequate sensitivity to those issues.
Yeah, I'm sorry that folks feel that way. Certainly, our intention is for all those considerations to be taken into account. One of the challenges, though, sir, that we have to work through is the super subspecialization of care in America. And in some locations of relatively rural America, as you mentioned, it is a couple. I've been stationed at Fort Lewis in the past. It takes some time to get from Whidbey Island or from Bremerton to Seattle, where super specialty care is delivered, but there's not enough requirement for it within the greater Bremerton area or the greater Whidbey Island area. So how do we balance the service members and family members who are stationed there using our exceptional family member programs, as well as delivering primary and specialty care in those locations? That's the balance that we have to work through. And even today, what are the requirements are different than what might be the requirements a year from now or 5 years from now. So that's how we have to work together. Over.
Thanks, Madam Chair. I'm out of time. I yield back.
Thank you. If you have more questions, please submit them for the record. I'd be interested in the follow-up. Mr. Diaz-Balart, you are joining us as anonymous from phone. Welcome. And I will let you know when you're at 4 minutes. Mr. Diaz-Balart, we're going to give you a minute to figure out how to unmute yourself and join us, and go to Mr. Aguilar. Mr. Aguilar.
Thank you, Madam Chair. Admiral Gillingham, early in the pandemic, COVID-19 infected 1,200 sailors on the USS Roosevelt, which had nearly 4,800 personnel. In your written testimony, you note that this outbreak was studied and a final report on the outbreak was published in the New England Journal of Medicine. What was the Navy and the scientific community at large learn about COVID-19 from the initial outbreak?
Yes, thank you, sir, for that question. I think that one of the primary lessons learned, and it was one of the first works that demonstrated the asymptomatic transmission of the virus. About 50% of those that were infected aboard Roosevelt became so through asymptomatic transmission. So other additional findings told us about the latency of the virus that worked out to be about 10 days. Our scientists did viral cultures and were able to demonstrate that. And so the key though is that we were able to take that information in real time and generalize it across the fleet in the Marine Corps to prevent further outbreaks. We did have one additional outbreak aboard USS Kidd, one of our destroyers operating in the Southcom AOR. But because of what we learned there, the impact was much less, and we were able to get Kidd back to sea much quicker. And subsequently, we have had none of our ships miss operational commitments as a result. So it really was a tremendous collaboration between our scientists, public health experts, and the CDC to do that initial evaluation and quickly use that information and rapid cycle feedback to change the way we operate.
Were there other outcomes in the journal and in the study that led to a change in operations?
Well, you mentioned the article published in New England Journal. A companion piece was also published actually on Veterans Day last year from our study of a prospective study of Marine recruits at Parris Island. And that also testified to or really demonstrated how pernicious the virus is. Even in that tightly controlled environment, there were still six separate sources of virus entering the cohorts there at Parris Island. Also did, though, emphasize the relative asymptomatic and less severe nature among that young adult population. And those lessons, I think, were valuable to share to other congregate settings, such as universities and schools.
I appreciate the answer. This question is for the Surgeons General. The pandemic has placed significant burdens on the stress of service members and their families. However, throughout the pandemic, the conversation around mental health has shifted away from a taboo topic to one that is integrated in our healthcare conversations. What are you doing within your authorities to ensure ready access to mental health services?
I'll go ahead and start, sir. We have found tremendous value in embedding mental health personnel with our both with the fleet and in the field with the Marine Corps. 35% of our professional mental health specialists are outside the medical treatment facility. I think I'd also emphasize that we also know that a big part of mental wellness is resilience. And so we've put a lot of effort on trying to stay to the left of actual specific mental illness by fostering resiliency and life skills. About 40% of our sailors and Marines that do come to mental health care do so because of an adjustment disorder. And we have piloted programs at our Recruit Training Command, where we now provide stress reduction, lessons in stress reduction, such as meditation. And we're extending that to the fleet with our enhanced operational stress control efforts.
Yes, and so in the Air Force, it's really about focusing in on connectedness, because that's really where it starts, I think, in how do we get the entire community around these individuals to help them work through the issues and the challenges that we're having. So ensuring leadership engagement, equipping and empowering families. Oftentimes they're going to be the first ones to notice a change. And so what kind of avenues do they have in order to get help for themselves or their members? And then also time-based prevention. So, making sure that we are taking away some of those means that somebody would use to hurt themselves, guns, drugs, because we all know that, if somebody is going to consider ending their life, they'll do it in the first 5 minutes. And so taking away those means where they don't have that around them might decrease that. And so it's really about creating a community and a connectedness to the whole system.
Thank you so much. I didn't get to all of you, but my time is up. I yield back, Madam Chair.
Thank you. We're going to have time for another round of questions, Mr. Aguilar. Mr. Diaz-Balart, can you join us? I thought that you had worked your magic to be unmuted. You are unmuted, but we're not hearing you. I'm disappointed for you and with you. Ms. Capter.
Hello, Madam Chair. Can you hear me?
Yes, I can.
All right. Thank you very much. Thank you for organizing this hearing. And I want to thank all of our distinguished guests this morning. My interest, I want to thank them for their service to our country during this difficult time. You are distinguishing yourselves. When the 101st Airborne landed in Cleveland and were giving out vaccines, I thought, now I've seen the world change, and they've made such a huge difference. So my interest is in human performance and brain-related conditions, medical conditions that onset due to stress, to injury, or to preconditions of that individual due to violent incidents prior to enlistment in the armed services. Conditions like biochemical imbalances, where serotonin and dopamine aren't being released in the proper way, mood disorders, PTS, bipolar, schizoaffective disorder, schizophrenia, paranoia, to name a few. Impulsive, I think they call it compulsive disorder. Anyway, I would like to know from DOD's vast reservoir of knowledge how to gather the experts from your department and perhaps the Department of Energy, where we have our massive research labs with our imaging and supercomputing capacity, to take a look at better diagnosis. What do we know about diagnosing these conditions? What are we doing for better pharmacological innovation? And how are we working with the major brain banks in the country, such as exist at the Stanley Foundation and in Boston, to put information up on supercomputers to look at what's going on in the brain? So who are the people within the department who are working on in this arena? When the Admiral of the Fifth Fleet took his life in Bahrain, it had a major impact on me because we just met him in Tampa about a year before that. So this whole diagnostic area, research area, is important. And then secondly, the education role that the DoD can play by helping meet the major shortage we have of doctors that work in this field. It's about 100,000 short in our country right now, along with 4 times that many advanced practice nurses. What can we do in loan forgiveness to attract individuals to this field after they have graduated from medical school and can serve in the military, serve our personnel, but maybe even do some work in the civilian sector somehow related to that? So I'm very, very interested in who, this is probably not the moment to go into all this, but who at DoD could we gather? I'm still looking for thousands of DNA samples that were taken by the Ohio National Guard in relation to these conditions, and I don't know where they've been stored. But part of the study that was done with the Ohio Guard showed that part of the reason for the declining human performance in those voluntarily giving their DNA that had these conditions onset was that their brains had been injured prior to enlistment, where they had been a part of violent incidents before going into the military. So I'm interested in the brain, human brain, and human performance. I wonder if you could at least comment on that and see if there's a way we can have a roundtable. I'm not the only member who's interested in brain condition and human performance from what I've listened on the panel this morning. So could anyone comment, please?
I think I'll start and then have my colleagues jump in. I think you bring up a very large topic, and brain health is a priority for the department. So you brought up about research. We do have significant investments in PTSD, mental health disorders, brain injuries, and the like. In fact, we just started a new, it's not that new, but it's been a few years old, Warfighter Brain Health, where, for example, we are proposing to do neuropsychological assessments on all service members that access, and then periodically do reassessment. So that's just one example, but we do have significant investments in research. And as you've alluded to, we work with the Department of Veterans Affairs, as well as academia and multiple places. I think some of the ones you mentioned we are working with. Second of all, with regard to education, we also have big input into educating our service members. And lastly, you mentioned recruitment and the tools that we have to recruit those people who are behavioral health specialists. We do have tools for that include things like bonuses, accession bonuses, retention bonuses that the military departments can use to attract and retain those specialists that are priorities. So those are some of the top line answers to what you've asked, and then I'll turn it over to anybody else who'd like to contribute.
Ms. Capper, you packed a lot into 5 minutes with more follow-up to come. So that was...
Madam Chair, thank you for having this hearing. This is great. I congratulate you.
So, Mr. Calvert, we're going to do a second round. Do you want to go first, or do you want to go at the end with me? Your choice.
Hold Can you hear me all right?
I can hear you now.
Why don't we wait to the end? We'll just finish it up.
Okay, Mr. Ryan.
Thank you, Madam Chair. I just kind of want to follow up a little bit on what Mr. Aguilar was talking about and Henry Cuellar was talking about. If you could share with us, I got a brief the other day, but I'd love for the committee to hear about the spiritual readiness program. Are any of you familiar with that pilot program that the chaplains are taking on?
Yes, sir. This is General Dingle. The Chaplain Integration Program is a program that the Department of the Army chaplain and myself came together to help synergize our efforts versus having them stovepipe. In the past, we've never really synchronized the ability and the talent of our chaplains who play a large role in the prevention of suicides with our medical professionals. So we implemented what's called the CHIP, the Chaplain Integration Program, in which we're synergizing, emphasizing, educating, and training, not just our providers to leverage each other and share information, but as well as getting that information education out to the force, in addition to our embedded behavioral health assets.
Okay, great. I think this is a program, after getting briefed on it, Madam Chair, I'd love for the committee to at least get a one pager on it where the chaplains are really integrating some of these practices around mindfulness and other practices really to help connect a lot of the rank and file members to each other and do it through the chaplain corps. So I think it's a great opportunity for us to really play some offense with some of the mental health promotion and really giving the soldiers the tools they need to be able to kind of withstand some and build some resiliency given all of the economic and other stressors that they have. So I just wanted to make sure we brought that up in this hearing. So anyway, I'll yield back, Madam Chair. Thank you.
Thank you. And the chaplain corps is really, really important. I know that from guard deployments to being with active duty, and that the work that they do is really important. They're sometimes the first call for help or resources. So I agree with you. We need to get some more information on that. Mr. Cuellar, and then Mr. Aguilar, then Ms. Capter, and then Mr. Calvert, and I will close.
All
Mr.
right.
Cuellar.
Thank you, Madam Chair. Thank you, Madam Chair. I want to follow up what my colleague, Mr. Ryan, and I have been talking about is on that HPO. I know y'all going to put that information together, but make sure, as the chairwoman said, that y'all tell us what different higher education institutions you're working with, what the different parts of the departments are working on this, what the military academies are working on. So when you put all that together on all the areas that we talked about, that Mr. Ryan and myself had talked about and other members, just have something very comprehensive and make sure we have a consolidated inventory, a one-stop center for all this, because it looks like, you know, every agency does, every armed service does something a little different. And I know what the Air Force does. I have an idea what the Army does, but we got to make sure we learn the best practices from each other and start off, especially with our military academies where they start off with. So that should be it. Just follow up on that. And Madam Chair, I yield back to balance my time. Thank you so much.
Thank you. I think the staff has been taking notes, and we'll figure out how to integrate not only these things into the president's budget as our committee priorities, but also how to follow through with future briefings. Mr. Aguilar.
Thanks, Madam Chair. And I'll pick up where I left off, and I don't believe I heard from General Dingle. What are we doing within your authority to ensure ready access to mental health services?
Yes, sir. And I was gonna add that in addition to what was already said, we also just completed a behavioral health assessment team comprehensive in the Army. And there were two things that was previously mentioned by my colleagues that they brought up. One was the isolation, and another was leadership. Those were two common things that we found in our assessment as we looked at the impact of COVID on our soldiers around the world. And so as we leveraged, again, their access to behavioral health with our embedded behavioral health is what we call in the Army, giving them greater access. But in the COVID environment, another thing that General Place mentioned earlier that just skyrocketed for us was the behavioral virtual health. The soldiers leveraging in an isolated environment, this COVID environment, our behavioral health virtual went up about 120%. And then in addition to that, as I do my battlefield circulation, the commanders in the field, they've also been the difference makers, leadership. So leadership involvement in their ranks and organizations, one, to help remove the stigma, but also to connect the force so that when they see their battle, we call it, this is my squad, knowing who is next to you, knowing to the left and right so that you can engage and intervene, has been tremendous. Over.
I appreciate it, General. I'll stick with you just for one additional question. GAO study found that the DoD had difficulty recruiting and retaining physicians across the specialties. And in your testimony, you stated that Army Medicine has been pursuing a couple approaches to support readiness and high quality medical care, one being Army graduate medical education, and then the other being military-civilian partnerships. Are you concerned about the difficulty that you're having in recruiting and retaining combat casualty care specialists?
So one thing, it is always my concern when we lose any of our medical professionals, especially our surgeons and our providers. However, as we've been losing our surgeons who will get out after their first term, especially those who enter service from the Health Professional Scholarship Program, we have an entire cohort that we graduate through USUs, as well as others who continue and who want to serve their country. One of the things that has just been a huge for us, in addition to the incentives and bonus pay that you all have given us, is our Civ to Mill partnerships. One of the big things that our surgeons, our providers want to do is they want to do surgeries. And us being able to leverage, again, the DHA and our health readiness platforms, but the Civ Mill partnerships have been a home run for the Army in the recruitment and the raising of that morale. And so it is my intent to expand those in conjunction with the DHA, providing the touches that we need and reps to maintain their acuity.
Thank you, General. Appreciate the answers. Thanks, Madam Chair, for the second round.
Thank you. Ms. Capter.
Thank you, Madam Chair, very much. I'll make it quick. What is the total amount of money that the DoD spends on mental health research, the behavioral research that I've been talking about that's brain related in a year? We know that the overall budget of the VA for research is about $800 million. I'm trying to get them to break it down for me. I don't know if you have those figures at the tip of your fingers or not. But then secondly, in terms of loan forgiveness as an attraction for people post medical school to be attracted into DoD as a physician, you mentioned some of the programs that you have, but do you have a loan forgiveness program where, let's say, a medical student has a $400,000 debt, you just relieve the debt to attract them into service? Or do you need authority to do that? Because frankly, I want to help you out. And then in terms of education, how do you use your uniform services to help in this specific area working with the Intrepid Center?
All right, so we're gonna have to break this down for each one. So the first one, with regard to the actual dollars that we spend for mental health, I can tell you, just like the VA, how much overall we spend in research, but for that, I'll need to take that away unless General Place happens to know that.
I don't, ma'am, sorry.
Yeah, no, we're happy to get you the dollar amount that we invest in mental health. That we do spend just under $1 billion in research overall.
And man, could I just interrupt you a second? When these folks come home and they come down to National Guard and reserve units in districts like mine, what happens is the care just like it dribbles away. And so the Guard and the Reserve, we have people who get sick and it's very hard to get care to them. So I'm trying to figure out in all these different pockets in the government, how much money we actually spend in the brain related areas for research and treatment, and how we attract medical personnel into this field. Okay, so I'm trying to help you out, but I got to get the big picture.
Very happy to provide that dollar amount that we invest in mental health, brain health to you. We'll take that back. The other question.
And what about authority? What about authority for education? Do you need more authority to pay the debt of someone who's graduated from medical school and could be attracted into the neuropsychiatric field, but it doesn't pay that much in the civilian sector compared to being an orthopedic doctor, right? We understand the foot. We don't understand the brain completely yet. So these docs go out there and we got shortages. In the jails that I represent, 40% of the inmates have mental illness of one form or another, and about 10% of them are vets. So what we have to do is figure this out as a country. And you're at the, you really have enormous power to attract, to inspire. And so I'm interested in your current authorities to educate, like through the Uniform Military Service, Medical Service. Can we do more there? Can we forgive loans? Can we create a new program? Are there authorities that have been given to you that aren't being fully exercised for education in this field?
We do have authorities, whether or not they're adequate, we can have that discussion. The authorities that we have are with regard to, bringing on students into the Uniformed Services University. We have training programs, and then we also have bonuses that we pay for a session and for retention that the military departments can use to keep those specialties, like the ones that you have said, the ones around mental health, in order to compete or better compete with the civilian sector. So we do have some of those authorities. Each department uses them based on their priorities. So.
We have a national crisis in this area. So, Madam Chair, my time is up, but I think a discussion with Chairman Takano at the VA, with Debbie Wasserman Schultz, with Rosa, with NIMH, the chair of the full committee, I think that would benefit us in this arena of health.
So we're going to have a question on workforce, and so the committee will be getting back to the panel so that we understand what you're doing with workforce on this issue when we have our committee on workforce, and we should have that captured by then. To the ranking member, Mr. Calvert.
Thank you, Madam Chair. I have a question on medical research. General Dingle, since the medical research currently falls under the Army and has for some time, I want to begin by asking you how we can best support our warfighters in this area. Congress routinely adds over $1 billion to the defense budget to fund specific areas of medical research. Last year, we added $1.8 billion, and the year before that, it was $1.6 billion. Even by defense standards, that's a lot of money. Can you please provide for us some examples of research initiatives that provide the greatest benefit for the health and readiness of our troops? And also, do you support the proposed transfer of medical research to the Defense Health Agency? Why or why not?
Yes, sir, Representative Calvert. As you know, we execute 35 research programs, and we manage about 4,500 or so research awards to include 500 clinical trials. All of those go toward the operational readiness of our soldiers, as well as treatment within our beneficiary population. The monies that you are providing us, again, we take great pride in being the stewards of that. However, we also acknowledge that, in the law, you have written for us to transition that research. We are working with the Defense Health Agency and Health Affairs on the way ahead, and how to meet the intent of the law. At the same time, again, we understand that, we're proud and we love what we do in managing and being great stewards of those monies. Over.
How about the Defense Health Agency issue?
Sir, if you're asking me, Ron Place from the Defense Health Agency, I think that the history and capabilities that the Army has done with medical research and development has been exceptional. I do think, though, that there are some benefits for standardizing within a joint force organization so that it can support all requirements across the department in a prioritized fashion. So I am in favor of what the Congress has done in the past to synchronize it within the Defense Health Agency. Over.
You don't think that's going to just create another bureaucracy that's going to be cumbersome?
No, sir. Our goal is to utilize the best practices that the Army has already demonstrated in MRDC. Over.
Okay. Thank you, Madam Chair. I yield back.
Thank you. I've got a couple of questions, and I think this one will go for the record, and it goes to workforce, and it's a follow-up from Mr. Kilmer. So, Doctor and General Place, $334.6 million was requested in the FY21 budget for buying back some of the capability lost with reductions of the military providers. Little information has been provided to justify the executability of the request and the funding that was not appropriated. Without asking about the FY22 request, what factors would give confidence to DoD that you would be able to obligate the hundreds of millions of dollars in one fiscal year? So that we'll take that for the record. And what is the average amount of time going to workforce it takes to get a civilian medical professional hired? And are you expecting to have problems recruiting experienced civilian doctors? And I think that came out loud and clear, but not just doctors, nurse practitioners, the extended medical family that you need to do that. A follow-up from Mr. Womack, who asked a really great question. Once again, Dr. Durham and General Pace, looking forward to FY22 budget. What impact do you think deferred care will have on healthcare utilization over the year? Now, you kind of left me with the impression that for service members, there probably isn't much deferred care, but there might be deferred care for family members and retirees who are using our facilities. So what impact do you think that deferred care will have on long-term costs and possible conditions detected during routine checkups or testing? Because procedures were postponed. And I'll use the example because I'm a great proponent of people keeping up on colonoscopies and testing so that we can reduce the amount of unnecessary deaths quite often from colon cancer if detected early enough. So if you could break those apart, maybe the service members were good on deferred. Nothing was deferred, but on families there were, and what potential costs you could see coming out of that. I also want to follow up on kind of where we are on the transition that appears to possibly be moving forward from removing civilian personnel families and that from receiving health care at some of the clinics. Where are you on that? That was a pause on COVID. Has COVID taught you anything more that we can learn from that? And I'll put that in a more formalized question. Additionally, I'm going to do a follow-up on COVID. We know that we learned a lot, and you learned a lot over the last year and a half, that life-saving PPE is it's masks, it's gloves, it's syringes. A lot of this is made overseas. Right now, you appear from the testimony that you gave, you were confident that the supply chain was not too vulnerable, but that doesn't mean that that couldn't happen next time if there was a pandemic, because we have a stress on the system currently. Hopefully the vaccines, enough people get vaccinated, we don't have reinfections with new strains and everything like that, but there has been a strain on our system. So I'd like to know what discussions are taking place with DoD about working to onshore more of these basic necessities, not only for military readiness, but for the national security of the entire population as well. And last but not least, it would not be a hearing if I did not talk about the Arctic. So I would like to know what is going on, an update on the Cold Weather Region Center of Excellence that we're working on establishing, where we are on the pilots, how long the pilot's going to go on. I'd like to look at your benchmarks or milestones. And as Mr. Rogers said, I will join him with a informal briefing, more on medical records. If any other members would like to join us, I know Mr. Calvert is always welcome, and we do things together as a team. If there's other members interested in that, please let us know. If staff, I know that you're listening on another channel, let us know if your members are interested in that. So a little extra homework. I would like to thank you for all the people who testified, and I'm going to paraphrase what the Army started out with. Thank you for your work in the foxhole, the cockpit, and the helm, all the way down to the facility, for the golden hour, and for those of you who are able to do the wonderful deliveries of our new Americans for the first hour of life. Please thank everybody who works under your command. Every job's important, from the nutritionist to the person who makes sure that that room is clean and healthy with what we're dealing with, bacteria resistance entities that are out there. Just thank you for all that you do. And to General Hogg, we just wish you the best in your retirement. We thank you for your service. Your expertise will be missed. We hope that you stay in touch and find another way to put all your expertise to work for all of us here in the United States. So as we close this hearing off with Memorial Day, especially coming up this weekend, we know how important your work is in making sure that we get the best medical attention to our servicemen and women when they need it, especially when they're in the battlefield, putting their lives on the line. With that, this meeting is adjourned, and I thank all of you and all the members today for joining us.